So am I audible?
Yes, yes, ma'am.
Okay.
Yes, madam.
Okay. So good evening all and welcome to this popular Unplanned Cut session. I'm Dr. Bharti Kashyap. I'm Chairperson Scientific Committee, Jharkhand Ophthalmological Society, and I'm welcoming you all for this Unplanned Cut session. This is a power-packed real-world surgical learning experience, which is being organized under the aegis of Jharkhand Ophthalmological Society. There will be a real unedited surgical videos, expert insights, interactive panel discussions, and there will be focus on what to do next. In this world of ophthalmic surgery, we strive for precision, predictability, yet every surgeon knows the adrenaline of the unexpected turn, those moments where surgical plan shifts in seconds to manage iatrogenic challenges or intraoperative surprises. Today's session is dedicated to these high-stakes scenarios, focusing on resilience and technical adaptability required to ensure the best outcomes for our patients. I would also like to acknowledge the support of our JHOS members, Dr. S.P. Jakhanwal, our President, Dr. Nilindu Mishra, our President-elect, Dr. S.K. Mitra, Vice President, Dr. Sujay Samanta, our Secretary, Dr. Sunil Kumar, Chairperson ARC, by Dr. Sunil Kumar. We are incredibly fortunate to have a stellar team of chairpersons and discussants who will be steering our discussions today. So the chairpersons and discussants, I am going to brief just one liner. Dr. B.P. Kashyap, he is the past president of Jharkhand Ophthalmological Society and ex-management committee member representing JHOS at AIMS. Dr. Subhas Tatia, he's a distinguished senior ophthalmologist, a pediatric ophthalmologist, and he is current director professor of Guru Nanak. He is today replaced by Dr. Arushi. She is a very efficient pediatric ophthalmologist working with him. So Dr. Nilindu Mishra, he is the president-elect of JHOS. Dr. Sujay Samanta, our already secretary and a high-volume cataract and glaucoma surgeon. On the screen, I can see someone. Is this Mr. Rahul Jain?
Rahul Jain.
Okay. So Dr. Sujay Samanta, show the doctors, not the endowed coordinator. Dr. Sujay Samanta is our honorary secretary and high-volume cataract and glaucoma surgeon. Professor Sunil Kumar is chairman ARC, Jharkhand Ophthalmological Society, and head of the department of the Regional Institute of Ophthalmology, RIORIMS. Dr. Rahul Prasad is the joint secretary of JHOS and is a professor of ophthalmology at RIORIMS Ranchi. Dr. Malay Verma is our treasurer and is a very fine oculoplastic surgeon trained at Sankara Netralaya, Chennai. Dr. Nitin Dhira is the CSC of ISO. Dr. Ankur Sinha is the secretary of is the secretary of Rajasthan Ophthalmological Society, and is currently contesting the election for the position of treasurer at the Glaucoma Society of and Glaucoma surgeon from Bihar, currently working in Buddha Eye Care and Research Service Center, Patna. Dr. Nida Anuradha is a young dynamic surgeon from Ranchi who is well trained in glaucoma and currently working in Bhagwan Mahavir Manipal Hospital, Ranchi. Dr. Indranath Prasad is a high-volume cataract and glaucoma surgeon at Prasad Eye Hospital, Ramgarh, and Archana Kumari is a vitreoretina surgeon at Prasad Eye Hospital, Ramgarh. It is now my distinct honor to invite a truly legendary personality to inaugurate our webinar, and this personality is none other than Dr. Namita Sharma, the chairperson of the Scientific Committee of All India Ophthalmological Society. Dr. Namita Sharma is an internationally acclaimed leader and one of the world's foremost researchers in cornea and refractive surgery. Her impact on our field is truly global. She has been recognized as one of the top 10 researchers in ophthalmology worldwide and is featured among the 100 most influential ophthalmologists according to the Asia Pacific Journal of Ophthalmology. Associated with the prestigious All India Institute of Medical Sciences, AIMS, her pioneering work in cornea transplantation and ocular surface disorder continues to guide surgeons across the globe. Beyond her surgical brilliance, she is a visionary for academic excellence and a source of inspiration for generations of eye surgeons. So, Dr. Namta Sharma, Madam, we are privileged to have you with us, and I now request you to kindly inaugurate this unplanned cut session.
Madam, may I add one sentence for Professor Namrata
But in a
Sharma?
planned way.
Yeah.
The topic is unplanned, but
She is the most powerful female ophthalmologist of the world.
yeah.
Unchallenged. Please go ahead.
Good.
Please proceed.
Madam, where are you?
You are muted, ma'am. Namrata, ma'am.
Thank you very much for your kind introduction, Dr. Bharti, and thank you so much for the honor, sir. It is my pleasure and my privilege to inaugurate this program on Unplanned Cut, which is being done under the aegis of Jharkhand Ophthalmological Society. And I would like to congratulate Dr. Bharti Kashyap and the entire team for this. Unplanned Cut was a program which I think witnessed and participated for the first time in Vidarbha Ophthalmological Society. And I'm thankful to Dr. Manoj Khatri, Dr. Viral Shah, Dr. Rajesh Joshi, Dr. Rahul, and the other participants who actually conducted it very well. And immediately we co-opted in the All India Ophthalmological Society annual meeting, which was in Jaipur.
Yes.
The concept is absolutely unique, and the concept is very novel because it deals with the complications which occur and how to actually solve them by a group of panelists as soon as they occur. And then the presenter himself or herself tells you how he or she solved it. So I think it's a great concept. Many congratulations. Thank you, Dr. Bharti and Dr. Viral Shah for coordinating on this unique program format. And I'm sure we are going to have great speakers, great videos, and great discussions. Thank you once again for having me to inaugurate this Unplanned Cut webinar. I'm sure it is going to go great guns in the physical format as well as the virtual format. Thank you.
Thank you, Dr. Namta, madam.
Thank you.
And
Thank you so
I'm
much,
really,
madam.
really thankful to Dr. Viral Shah, Dr. Manoj Khatri, Dr. Rahul, Dr. Joshi for allowing us to plan this, and they have assisted us very well. And now over to Dr. Sunil Kumar to introduce the moderators.
Thank you, ma'am. So it's my privilege to introduce all the moderator of the today's session, that is Unplanned Cut, and it is.
Is the slide visible?
Yes. Yeah.
So the first moderator is Dr. Manoj Khatri. He is the world-renowned vitreoretinal surgeon, as we all know, and he is the founder and managing director of the iDocs Eye Hospital, Chennai. And he is also the director of the Department of Vitreoretina at the Agrawal Eye Hospital, Chennai, and also the director of Department of Ophthalmology at Apollo Hospital, Chennai. And he is the recipient of the prestigious Gold Medal Award from the IRSI. And the post he holds is the treasurer of the VRSI. He has done so many live vitreoretinal surgery. He is the principal investigator of the various drug trials in ophthalmology. And he is also examiner for the FRCS as well as the DNB exam. And he also received one of the Community Service Award, that is the Service of Self, the Distinguished Service Award from the Honorable Governor of the Tamil Nadu. So I welcome Dr. Manoj Khatri sir as a moderator of this session. And the next moderator, next slide please. Yeah, so next we have the Dr. Viral Shah from the Niyakchi Eye Hospital, Nagpur. He is the president of the Vidarbha Ophthalmological Society, and he is also the vice president of the Maharashtra Ophthalmological Society. He is the member of the AIS Health Insurance and TPA Committee. He is among the advisory board member of the Ophthalmological Society of the Nagpur. And in the past, he also held so many positions like president of Ophthalmological Society Nagpur, chairman scientific committee BOS, honorary secretary MOS, member scientific committee MOS, ex-associate professor ophthalmology, and ex-joint secretary IMA Nagpur. So welcome Dr. Viral Shah as a moderator in this program. And next, our own Dr. Bharti Kashyap. She is the founder director of the Kashyap Memorial Eye Hospital, and she is also the medical director of the Kashyap Memorial Eye Bank. And she is the prolific femto-cataract as well as the refractive surgeon. And she has received so many awards, and she is the first woman ophthalmologist of the India who was felicitated with the Nari Shakti Puraskar Award in 2017 by none other than the Honorable President of India. She holds so many positions. She is the Chairman Scientific Committee of our Jharkhand Ophthalmological Society. She is the Chairperson, Women Doctors Wing, IMA Jharkhand. She is Secretary, Women Ophthalmological Society Jharkhand. She is the Secretary, Ranchi Ophthalmic Forum, ex-National Co-Chairperson, Women Doctors Wing, IMA Headquarters. And she has received so many.
You can bypass me.
Yeah, she has received so many awards and she has organized so many conferences in the Jharkhand Ranchi. So welcome, ma'am. And next is Dr. Rajesh Joshi. He is a professor head, Department of Ophthalmology, GMC Ophthalmal Maharashtra. And he is the editor general of Clinical Ophthalmology Research. It's a very good and reputed journal. He is the past president of Ophthalmological Society of Nagpur and West Ophthalmological Society. He is the recipient of the AIOS IG Award, Best Teacher Award by the MOS, as well as the Best Free Paper by the MOS and BOS. And he has nearly 100 publications and peer-reviewed journals. So welcome, Dr. Rajesh
Thank you,
Joshi.
sir. Thank you. Thank you.
And next moderator is Dr. Rahul Tiwari.
You can shorten because it's very long.
Yeah. He's a distinguished senior pediatric surgeon and director of Shivam Nesal in Nagpur. And he has so many degrees with all the FRCS, MRCS, FICO, FACS, FICO. So many awards and fellowship and so many things. And he has also done leadership as well as many presentations and awards. And I think some of the awards, the RC Meher Endowment Donation Award, the 6th annual meeting of the Equine Odisha State Chapter. He had won the prestigious Dr. Sudaria Award for the Best Surgical Video in Annual Bismarck Ophthalmological Society and runner of the Best Surgical Video at the MOS, Best Surgical Video, and so many awards. So welcome Dr. Rahul Tiwari for this program. So thank you very much to all.
Okay, so over to Dr. Viral Shah and Manoj Khatri, the moderators, to introduce the speakers and conduct the session.
Thank you so much, madam.
Thank you so much, madam, for the kind invitation for conducting this program in your esteemed society.
Welcome.
Thank you, madam. Thank you.
Thank you so much. Basically, it is we conducted this session for the first time. Am I audible?
Yeah, very much.
Yeah. So yes, for the first time in Vidra Ophthalmic Society, our chairman scientific committee, Dr. Rahul Tiwari, had this idea, and Dr. Manoj Khatri and Dr. Rohit Bang conducted it very nicely. Dr. Namrata madam, as our leadership quality, she was very keen to have in AIOS, and we did it in AIOS Jaipur, and now it's going to be a permanent fixture in the AIOS conferences. So our first speaker for today is Dr. Harshul Tak. He is a director of Rawat Eye and Phaco Surgery Center, Jaipur, and is also honorary secretary of Rajasthan Ophthalmic Society, and now newly elected ARC member from West Zone, from North Zone.
Got it wrong, Viral.
So Central Zone, sorry, Central Zone.
I'm a member scientific committee.
Okay, yeah, you are, okay, sorry, so sorry.
No.
He's now the member scientific committee along with in the team of Dr. Namrata, and he's also executive member of IRSI, Central Zone representative of ISCRS, and national advisor to IGO. And
top 3.
Yes, top second.
Top second.
And, we all know him as the admin of our LBO group. So welcome, Dr. Harshul, and you can start your video now.
Thank you so much. At the outset, thanks to Bharti ma'am, Kashyap sir, and entire Jharkhand Ophthalmic Society for this great initiative, and congrats to the team of Unplanned Cut, Dr. Viral, Dr. Manoj, Dr. Rajesh, and Dr. Rahul, who are so very good friends, and this to start this new session, and we really enjoyed participating in AIOS. Looking forward for many episodes of this session. So I'll be sharing the video. Can you see my screen now?
Yes, sir.
वो क्लियरली आ नहीं रहा है, क्या कर रहा है?
कोई स्क्रीन
Presentation is yet to be loaded.
Yeah. Is it seen now?
Yes,
Yeah.
Yes,
Now it is coming.
Okay, fine. So this was the case which was planned for a toric IOL implantation. The other eye of the patient was already implanted with toric IOL 6-8 months back, and this was also planned for toric IOL, and patient had astigmatism of around 1.5 diopter in this eye, and he had a small posterior subcapsular cataract also. So everything was routine, nothing special in the cataract surgery. I marked the steep axis where the toric IOL was planned to be implanted, and here the capsular axis was made, which was of perfect size needed for toric IOL. And this is my hydrodissection and hydrostitch cannula, which I use for hydrodissection. And so it was done, and the phaco was started, and layer by layer separation was done. And as you can see here, so after taking out nucleus, I was just planning to do irrigation aspiration. Before that, I was putting visco, and suddenly this happened. So cannula jumped off from the syringe, and this was not planned. So this was the unplanned cut here. And now I was just thinking that what all damage this cannula has done. So I just put irrigation aspiration cannula, but I realized that vitreous was already in the anterior chamber. So now I didn't want my vitreous to prolapse more, so I needed to maintain closed chamber. So I go ahead and put some visco, and I do bimanual vitrectomy, putting irrigation through one port through, and the vitrectomy cutter goes from the other side port. I do some vitreous staining there, and once I do vitreous staining, so this is the cut IA mode which I am using. So before changing my hands, I again go ahead and put OVD, and after doing good vitrectomy, I change to IA cut mode and use the same vitrector to take off this cortical matter. So the idea here is to clear off entire cortical matter, and again do visco exchange before changing my hands, and use the vitrector to take off cortical matter. And once you have done good vitrectomy, you can use a bimanual IA or the same vitrector to take off this cortical matter. So now as the cortical matter was being taken off, now the situation was clear to me that there was a big posterior capsule defect which has happened because of cannula, and also the major problem was the anterior capsule. As you can see here, anterior capsule is also ruptured. So had anterior capsule not been ruptured, I would have thought of somehow try to put toric IOL, but because anterior capsule was also ruptured, so there was no chance that I can put the toric IOL, especially in this axis. So, and unfortunately, the 3-piece IOL of, I think the power was 24 or something like that, and I didn't have 3-piece IOL of 23.5, which I use half a diopter less if you are putting in sulcus. Optic capture is also not possible in this case. So what I thought is, rather than doing anything, it's better to defer the IOL placement in the second stage, wait for a day or two, and I can plan a 3-piece IOL. So I'm just clearing off OVD there, and doing whatever vitrectomy and close the eye. And so IOL was deferred for next sitting. So on just after a day, again opened up the same incision. You can see clearly, put some viscoat there and enlarge the incision. And this is a 3-piece IOL which is going in. So it's important that you take care of the leading haptic when it's coming out, that it's always horizontal and it goes behind the pupillary margin. And as the optic comes out, you rotate your hand in anti-clockwise direction. And the trailing haptic is dialed in the sulcus, and IOL is placed in the sulcus, and again myocol is put, and this finishes the case. And I did surface ablation to correct corneal astigmatism after 1.5 months for this patient. So in the end, we had a satisfied patient with good result. So
you did not
thank you
have
very
the,
much.
Okay. So you did not have the power of
3-piece
three-piece.
IOL, yeah.
But it's
If
very-
I had 3-piece IOL
should have done in
of
the
the
same
appropriate power, of the
Ah.
needed power, I would have placed then and there itself. Yeah.
And your cannula, the loose cannula, which is sometimes happens because of the assistance fault.
Yeah,
That hit the anterior capsule and posterior capsule both.
Yeah.
Yeah, it happens sometimes.
So if anterior capsule was not ruptured, then you can try to put toric IOL. If you can manage posterior capsule nicely, if you know that you can put the toric IOL in the capsular bag, or even you can try to do reverse optic capture if your anterior capsule is intact. Otherwise, it's not possible. And my message to youngster or other surgeon is that it's not that you always have to put IOL if it's not appropriate. So you should be bold enough and you should be confident enough that yes, in the end you are going to deliver the result which patient needs. So if you are true to patient, they also understand.
Yes. And another thing about us.
So excellent surgery, Dr. Rashul. That was, you managed it very well.
Thank you, doctor.
But
Yeah,
as
thank
we
you.
all know, you have devised so many cannulas. You always concentrate on the tip of the cannulas. Sometimes you should also concentrate on the hub where it locks with the syringe.
But you said that reverse optic capture had it.
So
not-
these things happen, once in few
When your
years or like
assistant
that,
is-
Yeah, and
That is what.
of course we are always careful that we tighten the cannula nicely, and but
not
these
always
things
pure
do
lock, so-
happen. Yeah, these things do happen.
But don't we should not advise for the reverse optic capture, because reverse optic capture is a very dangerous thing. Optic capture is good, but reverse optic capture में बहुत problem है.
Dr.
ma'am,
Rajesh Joshi, sir, Dr. Rohit
if
Bang,
your
you want to say
antique
something?
Yes, so very well managed, Dr. Arshul.
Yeah,
Very well managed.
thank you, doctor.
Very well managed. But
Any inputs, sir?
the one message for young surgeon is that they should see that their cannula is well capped to the
Yes.
syringe. Otherwise, these
Exactly.
things happen. And sometimes the cannula may end up into vitreous cavity as well. So you should be very careful about this. Very nice surgery.
It is seen more often during hydro procedures, the cannula coming
Yes,
out
yes.
from the syringe rather than
Yes,
visco.
yes. Absolutely.
Yes,
Absolutely.
correct, absolutely.
Most of the time, it happens during the visco injection.
Yes.
Most of the time, because you are forcefully injecting the viscous into the interior chamber. And particularly if you are one hand engaged, you are trying to push the visco with the one hand only. Otherwise, you could have put your hand on the hub, then I put the injection all the time, maximum time, because I had some few cases last 20 years back. Since then, I had not any such type of event during the surgery.
Dr. Rohit Bang,
True.
you want to give some inputs?
Yeah, the only thing, like as we had discussed initially, maybe it would have been easier had the 3P Sile always be in our kitty as a library or something. So instead of taking the patient again into the OR, one of the procedures would have been avoided. But then
That's
overall,
true.
yes,
But very nicely managed, Dr.
very
Harsi,
well
and
managed.
it is
Yes.
very good message to the people and the neurosurgeons. You can always plan in second setting with good appropriate steps and all oil power calculation. Very nicely managed.
You should not
Excellent
be in a hurry.
presentation.
Yes.
Actually, like
For the second
just
talk,
Arshul sir, ये after 1.5
Yeah.
month आपने
Yeah.
surface ablation किया था या LASIK किया था?
Surface ablation. Surface ablation, yeah.
Why not LASIK?
Yeah, LASIK also you can do if you want.
No, my question is कि like already हम toric के लिए कर रहे हैं, secondary कर
Yeah,
रहे हैं.
so I for refractive surprises, I prefer surface ablation.
because
Why?
it is safe.
Because these are usually small corrections, 1.5, 2 sometimes, So for those, I personally prefer surface ablation.
But sir,
LASIK also you can do.
haze
Yeah.
कितना आता है sir after surface
No.
ablation?
So haze is an issue if you correct power which is more than 4 or 5 diopters, and in with the use of mitomycin with smaller powers like 1.5, 2 diopters, haze is almost not an issue.
And refractive stability आने में कितना time लगता है?
So once you do
Oh, no.
surface ablation, it takes 10-15 days for epithelium to heal and everything. Yeah.
Because I usually prefer to do LASIK
Yeah.
after a month because it gives you more predictable in terms of refractive stability.
So refractive stability is same. Either you do surface ablation or you do LASIK.
सर
So
ये
we do
टॉरिक में ना बेसिकली जो सिलेंडर्स के केस में मुझे ये सरफेस एब्लेशन थोड़ा अनप्रेडिक्टेबल लगता है.
no. If you have power which is more than maybe 4 diopter, or if you have a 4. See, I had a case which was operated somewhere else, and he was planned for toric IOL, but I think incidentally PCR occurred, and that surgeon couldn't put toric IOL. So that patient had almost cylinder of 4.5 diopters. So I did toric IOL in other eye and convinced the patient to do LASIK. So for that higher power, I did LASIK. So for smaller power, for 1.5 to 2.5, it won't make any difference. Either you do surface ablation or you do LASIK.
Right. Nice, sir, but absolute awesome surgery. Very good.
Great
Thank you,
case, Dr. Harshul. Congratulations.
Can the
Now we'll move.
speakers ask the questions?
Yeah.
Hello everyone. Can the speakers ask the questions?
Please go ahead,
Yeah,
madam.
Arshul, just one question. Sometimes the epithelial recovery, like hyperplasia, occurs after ablation. So nowadays, a lot of epithelial mapping is done. So sometimes it might go up to say 100 microns, 120 microns also has been reported. So I differ with this thing that it should go by LASIK, I suppose. Your opinion,
So we, yeah, it can happen, hyperplasia or whatever, it can
Yeah, so
happen.
it
But see,
induces-
we are routinely also in cases which are for defense services, whose corneal thickness is less, we go for surface ablation.
Yeah.
So-
That's true. That's true.
So
But
if it
why
has
I
to
am
happen,
saying
it can
that-
happen in any case. Yeah.
So if the epithelium is thickened, say about 100 microns or 110 or something like that, it can induce again a cylinder of 1.5. The epithelium
Yes.
itself is accountable for the cylinder.
Actually, that was also my question. मैं यही पूछना चाह रहा था कि ये अनस्टेबिलिटी जो है ना काफी देखने को मिलता है आफ्टर सरफेस एब्लेशन.
So we have been doing surface as well as LASIK as well as for last 15 years. So for till 4 or 5 diopters, I do surface depending on if patient is for defense services or for patient corneal the thickness is less. So what we have seen is in our set of patients in this, I don't see much of difference in results of LASIK and surface ablation. For higher powers, yeah, I don't prefer surface ablation more than 4.5 or 5 diopter.
Okay.
May I put in a
Well
word?
taken point.
May I put in a word?
Yeah.
Yes,
Please,
yes.
sir.
Fantastically managed, Dr. Harshad. Fantastic. Yeah, I'm telling you.
Sir.
So, you know what I have learned, and I'll tell my younger colleagues to note that when there is a posterior capsular cataract, you have to, use all those OCT anterior segment to see what is the extent, whether there is a plaque or not. And then if you find this, two things you have to do. Number one, you have to keep this spare 3-piece foldable IOL, number one. And number two, you have to mention in the patient's paper that this is a situation and the patient may land up in this situation, secondary IOL, second surgery. And if you don't know if the vitreous is more and then you do a vitrectomy, there might be some decompensation, then probably the corneal surgery. You have to mention all these things. And number three, I totally agree with Dr. Nagendra Prasad when he said, I do it whenever I inject any medicine in the anterior chamber. I always hold the hub. Whether it is a trypan blue or a viscoat or whatever it is. I always hold it because in previous years I had this problem, so I have learned the lesson. I always hold the hub before I inject anything in the anterior chamber. Thank you very much. Fantastically managed, Harshad.
Thank you, everyone.
Thank you, sir.
Yeah. So now we move ahead to the next speaker. Next speaker is Dr. Shubhangi Bhave Madam from Nagpur. She is a recipient of AIS IG Awards. She is a PG teacher, past president of NAO US, scientific chairman of scientific committee chairman of US, and also past president of Strabismus and Pediatric Ophthalmological Society, India 2023-24. Welcome, madam. You can start your case. You can start sharing your screen.
And the discussant in this case is Dr. Arushi. I think she's here. Dr. Arushi, are you here?
Yes, ma'am, I'm here.
Okay.
Can you see my
Yes, madam. Yes, clearly.
Yeah. So thanks for this invite. I'm speaking on this case of large exotropia presented with very large
Madam,
angle of
yes.
exotropia.
Madam, can you turn down the volume of the music? Yes.
The vision though was very good, 6/9 in each eye, but there was a large adduction deficit in both the eyes, right eye more than left eye. He wanted to get his eyes corrected. And looking at this clinical picture, I was also fairly confident that we can give him a good result. What we did was we did a bilateral recession of 18 millimeters on hemi-hangback, which you can see. The lateral rectus was quite tight. The medial rectus was explored. It was hypoplastic and lax and toneless. And we did a modified Nishidas to medial rectus on right eye. But what happened post-op was he continued to have a large exo. So what to do now? This result was not expected. So we tried again. So though we had recess the lateral rectus, I thought of doing a full muscle transposition and sparing the arteries because I was afraid of anterior segment ischemia. So the superior rectus and inferior rectus were transposed to the medial rectus, and an augmentation suture was taken. You can also notice a very hypoplastic muscle even on the left side. But again, the eyes refused to align, and I was at a loss to explain to the patient how this has happened. What else could we have done? Would LR transposition to MR would have helped us better than what I did? Thanks for watching the video.
Great efforts put there, madam. We don't know. Have we got Dr. Kavita also with us? Dr. Arushi. Yes, Dr. Arushi, you want to say something?
Yes, thank you, sir. Ma'am, very interesting case. I just wanted to ask what could be the reason for non-alignment of the eyes in this case, since you've tried both the procedures?
Only thing I can think of is maybe the LR was too tight, and even that 18 millimeter recession of LR didn't work. But that was also surprising because it really, it's a large recession, and I put it even on hemi hangback. I just didn't do a hangback. So the first suture, we took it at 10 millimeters and further hung it back by 8 millimeters. So that I'm at a loss to explain because the other muscles appeared quite normal.
Yes, ma'am. Ma'am, do you think a periosteal fixation at the medial side would have helped in this case?
Yeah, that was a retrospective thinking after we got the result, but with normal vertical muscles,
Yes.
it is difficult to fix the muscle medially on the periosteum. In third nerve palsy, when the vertical movements are not there, it is easier to fix the muscle medially. But with normal vertical movements, it is difficult to fix the muscle medially.
Okay, thank you so much.
Can I add, ma'am?
Have you done the MRI pre-op and post-op in this case?
MRI I didn't do.
Yeah.
But only thing is that I was suspecting a hypoplastic muscle. But I don't think I would have got any additional information.
Yeah, but we know the attachment of the lateral rectus. We have planned 18, but we have done hemi hangback, so we don't know where it has attached. First point. Second point is MRI tells us any central reason also for exotropia. So which cannot be treated. If we treat extraocular muscles, it is not going to help if it is the central cause.
Because
And
it was since
third
birth.
thing, which I felt was you planned to transpose the verticals to the medial rectus, right? But why did not you plan the transposition rather than this?
So initially, since we were recessing the lateral rectus, I did Nishidas in one eye. And in the second eye, since we didn't get a good result, I planned a full tendon transplant to the medial rectus. I did, in the other eye, I did a full tendon transplant, a vessel sparing.
But
What was the FDT finding initially?
Yeah,
Post-junction test.
FDT was somewhat tight for lateral rectus. It is expected in such a large exotropia. Long
Yeah, I
standing.
also had a
Can I
case
add,
last
Shubhangi
year.
ma'am? Ankur here.
Yeah.
Ma'am, we had a tight LR, so we cannot transfer the LR to MR in this case.
Yeah, that also was
So
difficult.
that is actually a ruled out thing right here. But what I would also see was a little bit of divergence in the down gaze if you look at it. So maybe it was a partial third nerve which has gone into a large angle exo. Whether it's a central cause or a peripheral cause, like whenever we are planning a third nerve, we still can hook on to the anchor, periosteal anchor in the medial side. So I think once the Nishidas doesn't work, probably the choice could have been from my side would have been a periosteal anchor rather than trying anything else. And doing a hangback of 18, hemi hangback of 18 millimeters, I think you have gone actually post equator for the lateral rectus. But still, no matter how far we go, lateral rectus still comes back and pulls the muscle. So maybe a kind of periosteal fixation of lateral rectus was also kind of one option along with the anchoring of the medial rectus with the tenectomy of the superior oblique. Now, this could have been one chance for him to get, although, difficult in long surgery, but yes, maybe.
It's with the full vertical movements, a normal pupil, no ptosis. Clinically, I wouldn't put it as a third nerve palsy.
Maybe a partially recovered or a partial third nerve, maybe. I mean, that's what we can
because
very rare.
Both the eyes having similar exotropia, no concomitants. So clinically, there was no evidence of third nerve palsy.
Yeah.
But the thought of periosteal anchoring of eye had crossed my mind, but since there were normal vertical movements.
No, it works well, man. We have done many, it works well. The anchoring works well even with the vertical muscles working.
Anyway, that we can try even now if the patient is
yeah.
We sure hope, madam, the patient will be very much willing if you counsel one more time, and we'll get to hear a new song
and offer him
post-surgery.
Surgery, then only
and in the new video, we'll see a new song. So it's usually very frustrating when you plan so much before cutting the patient, and at the end you think you should not have planned the surgery. So that's what happens. So thank you so much, madam, for any more comments from any panelists. So we move to the third.
Madam, what is experience in transpositioning the medial rectus to the lateral rectus origin?
Yeah, certain points one has to remember that the lateral rectus has to be tight. We have to divide the lateral rectus far behind, so that then only it comes easily to the medial rectus and gives a good result. But the lateral rectus has to be has not to be too tight.
Long time back, when all these newer technologies were not tried, I have even tried one thing. Please do not laugh. I just chopped off the lateral rectus and the patient become, the eye was straight.
Yeah, it wouldn't work, but in this case, because
yeah, I know.
So thank you so much, everyone. So next speaker is Dr. Manish Wankhede. He is a prolific anterior segment surgeon based in Khamgaon. He is working at Sri Gajanan Netra Rugunalaya, his own state-of-the-art eye hospital. He is also now the organizing secretary for our forthcoming WOSCON, Wither Ophthalmic Society's annual conference to be held in Khamgaon, Drushtikon. So welcome, Dr. Manish, and you can now start sharing your screen and start your piece.
Thank you, sir. Thank you for the invitation and a nice introduction. Sir, I feel honored to be here and to present my case.
It's visible now.
Yes.
Yeah, visible.
Yes.
Video has been stopped.
Okay.
Only home screen is being seen. Yes. There is no sound there, so you will have to speak.
Sir, sound येतोय का?
No, there is no sound in the video. You can do it from your side.
Okay.
You can play the video. Video is not moving forward.
Yes, sir. 1 minute, please. Sir, audio is visible? Audible,
No,
sir?
no, there is no audio. We can hear you, but not from the screen. Your video has no audio there.
Okay.
Dr. Manish, you need
Yeah.
to
Video is
stop sharing
paused.
once, and when you start sharing, before that you select audio also. Then that audio will come. No,
Okay.
you stop sharing once.
It is paused, I believe.
Now you can start again.
But click on share sound also. Yeah.
Should I share now?
Yeah, please. Have you selected sound
a
also?
case of 60
Yeah.
year
Now we can hear. Go ahead.
old female who is one-eyed, high myopic, and have a hypermature cataract. Most of her lower one-third of the cornea is covered by a dense vascularized corneal opacity. She is desperate to see the world, and it was difficult to take the decision whether to operate this case in a private institute or not. But I took the chance and started the case. To plan with the initial small microrhexis was intended so that I can plan and extend the rhexis on latter part. So initially starting with a needle and then completing a miniature rhexis with the help of forceps, washing all the loose cortex with the irrigation aspiration cannula will remove the tension inside the capsular bag, and this will help us to enlarge our rhexis with the help of forceps. So, again injecting the viscoelastics inside the anterior chamber and filling the bag with the viscoelastic so that there is a very small nucleus floating inside the bag can be handled. Taking the incision over the capsular rim with the help of microrhexis scissor and slowly enlarging the capsule and the rhexis with the help of microrhexis forceps. Actually, as initial part, I lose the control over the capsule due to corneal opacity as it was not visible, and it was again a better because the capsule larger part of the rhexis open area was in the visible part of the cornea. And now we will start with the phacoemulsification procedure. There was a major challenge in the phacoemulsification. It is a high myopic eye, a small nucleus, and it is small but hard, and there is a loose bag, and most of the area is not visible due to overlying corneal opacity. So to start with, I adopted a new technique in which I shifted in between chop and quadrantry mole. So you can see I moved the nucleus in a visible part of the cornea, chopped it, and once the chopping is completed, the separated piece is then removed with the help of quadrantry mole again. Again shifting to the chop mode, again moving the nucleus in a visible part of the cornea, moving it away from the opacity so I can visualize it, and then visible nucleus is chopped, part is separated, and again shifting to the quadrant mode, the nucleus, the separated part is removed, again moving the nucleus, and this procedure goes on until the whole of the nucleus is removed. Once the nucleus is completely removed, bag and antechamber is filled with the viscoelastic, and exactly what we have followed while removing the nucleus, opposite thing is done while removing the cortex. First, the cortex below the opacity is removed, and then the cortex below the visible area of the cornea is removed, so that we will be sure that there is always a cortical support while removing the blindly the cortex below the opacity. So there is an opposite approach while removing the nucleus and while removing the loose cortex. The single piece hydrophobic monofocal IOL was implanted in the bag, and once the IOL is implanted in the bag, make sure that the whole of the both of the haptics are below the capsule. So this is 3.5 diopter intraocular lens, which was ordered by an Indian company. And once the IOL is implanted, the complete removal of viscoelastic is very much important, because in such large, high myopic eyes, there is always a chances of left behind the viscoelastics, which can later date create an inflammatory reaction. To make the patient more and more gain from this corner cataract surgery, I injected a pilocarpine and triamcinolone acetate inside the anterior chamber and decided to go ahead with a optical iridectomy. So, with the help of micro scissor, multiple small incisions were taken on pupillary sphincters so that it will remain dilated in the area where the cornea is clear, so patient can gain maximum vision, and it will not be get hampered when the pupil will get smaller. So this optical iridectomy will help the patient to see more and more in the upper part of the cornea. Thank you very much. After day 15, patient has received the vision of 618, which is more than her expectation and our expectation, and will definitely change the way she wants to see the world. Thank you.
We can use endo-illuminator in this case, in such cases, in corneal opacity. Yes. We use in our hospital, and it makes life very easy. What do you say, Dr. BP Kashyap, sir?
Yeah, I mean, you should have an expert assistant with you, because both the hands are busy. So the other person, the assistant, has to show the illuminator, and the person should know from where to throw the light, from where the tip of the end illuminator should lie, whether the limbus or the ciliary body or the cornea. And then to your instruction, the assistant should move the end illuminator towards that side where you see it, where the visibility becomes very good. So end illuminator really helps you, but then you need an expert assistant for that.
And many times we put it in the inside.
Yeah. You can put tilting the eye towards
Yes. Dr. Nitin, yeah.
Yeah, tilting the eye towards the opacity could have also helped. I mean, especially pulling the under the opacity, which were the cortical matter or even the small piece, you could have tilted the eye towards the opacity, and those maneuver could have been, helpful. Though the large part of the cornea was, since it was, clear, so the surgery was not that much.
No, I'll disagree here. In this case, in this particular case, the opacity was pretty large. So even the tilting would not have helped probably. This is what I saw. So whatever is done, I think is fantastic. Plus the end illuminator could have added to your facility and visibility.
Endo illuminator helps a lot.
Endo illuminator will not be available with all the operating surgeons. So he has tackled the case in a very nice way.
Very nice.
Yes. Dr. Manish, was there any need to do the anidectomy at the end?
Sir, I thought the enlarging the pupil will help to see the patient above the opacity. But nowadays, I'm also coming across many expert opinions which say that whenever the pupil is very pinpoint, it reduces the distortion of the visual quality. So there are also opinions that we should make the pupil more pinpoint rather than enlarging into the area where it is clear.
Or you should have let it be unplanned.
Yes.
The cut should have been not planned. Yes, Dr. Rohit Bang. Rohit, you want to put in some?
Actually, the age-old theory had been we could have done as he has rightly done a optical iridectomy sort of. But if it's a one-eyed patient, it may be definitely it helps. But if the other eye is a seeing eye, in such cases, with optical iridectomy, there is a lot of glare and halos, and the patient tends to see with a better eye. In such cases, maybe the newer school of thought where doing a pinpoint pupilloplasty and making sure that the cornea is clear in that area, it helps. It reduces astigmatism, it reduces a lot of glare and halos.
Sir, let us not forget that the patient is one-eyed patient and the patient was blind since very, very long. The main idea of doing the operation is the patient sees the world. Now, whatever he has done, he has taken care that in the later period of our life also, the pupil remains dilated and there is some problem. If there is some retinal problem because the patient is highly myopic, it will help. of putting doing a pinpoint paper plastic. It's not all that easy. You have to the PRC arrest so many times, and you're creating a lot of giving a lot of information. I think he has done a superb job. Superb job.
Correct.
Thank you. Great surgery, Manish. Thank you
Thank
so
you,
much for joining us. Now the next speaker is Dr. Kavita Podwal. Yes. So Dr. Kavita is Senior Consultant Pediatric Ophthalmic Strabismus and Refractive Surgery and Advanced Fellowship from New Vision Laser Center, Baroda, and many more laurels to her. She is also recipient of Professor Kamlesh Gold Medal for Best Scientific Paper at SPOCI. She is Vice President of Indore Divisional Ophthalmic Society, Organizing Secretary of high-dose Conference Ophthalmology Tomorrow 2025. She is a well-renowned speaker and course instructor at various national international conferences, and she is a prolific writer also, published in so many journals. Welcome, Kavita Madam, and you can now start sharing your screen.
So my screen is there?
Yeah, visible, madam.
Yeah. So thank you, Dr. Viral, for the kind introduction.
No, it's not visible.
It's not
No,
visible.
it's visible. No, it's visible. Visible.
It's not visible to us. Yes, visible.
Can you reduce the volume, madam? Reduce the volume.
Dr. Arushi, are you here?
Yes, ma'am. Yes, ma'am.
Okay, so you are a pediatric ophthalmologist and you are dealing with squint also.
Yes, ma'am.
So your comment, please.
Yes, ma'am. That was a great case, ma'am. I'm surprised that the whole medial rectus was found that easily. Ma'am, what do you think was the cause of this medial rectus disinsertion? Was the initial dissection by the retina surgeon inadequate?
Yeah, actually, what happened? I just want to convey one message through this video is that lipodermoids, the conjunctiva is so adherent to the muscle and everything. So while dissecting the conjunctiva, only the surgeon chops off the rectus if he doesn't take care. Okay, because it is adherent to the muscle capsule. And so it was by mistake, it was chopped off, and a lot of fishing was done on the posterior side. But ultimately, we found out that when you evert the conjunctiva and see, you can see some muscle fibers on the conjunctival side, and then you find out the muscle fibers, and then you take it off and attach it to the proper place.
Yes, ma'am. Ma'am, do you suggest anything for the retina surgeon if they come across this condition?
Yeah, in
What
such
should they
cases,
not do in such conditions?
yeah, they should not go beyond they should dissect the conjunctiva only and the anterior to the medial rectus, not beyond that.
Yes, and ma'am, I'd like to add that they should not look for the muscle by rotating the eye in the opposite direction, and because that may cause the muscle to retract even further back.
Yeah.
Yes, ma'am.
Yes,
Fun.
Shivangi, madam.
Can I
Yeah, please.
ask?
Yeah, yeah. Yes, please.
Yeah. Since it is very difficult to retrieve a medial rectus, rest of the muscles have some attachments. So lateral rectus, inferior rectus, but medial rectus has no attachment. So have you any time needed a combined approach to retrieve the medial rectus?
Pardon, madam, I'm not able to hear. Can you be a bit louder?
Did you require a combined approach sometime to retrieve the lost medial rectus?
What do you mean by combined approach? Like
that is doing an orbitotomy or
no. Actually, you can do MRI later also. Sometimes you can postpone you can just do all the complete finish of the surgery, then do the MRI, find the placement of the medial rectus, and then according to the MRI, you again retrieve the medial rectus and reattach it on the position. But for this case, I have presented so that people know that the attachment of medial rectus capsule and the muscle to the lipoderm, which was on the conjunctival surface, which is the culprit for this. So in all such cases, don't go beyond the insertion, that is 5.5. Don't go beyond that. Just anterior to that, you dissect the conjunctiva. Don't try to dissect. Even if it is attached, let it be attached.
Just want to add one thing, that normally when the pitting of the medial rectus occurs, it is usually 5 millimeters further behind the insertion. So, and this you were lucky enough to have just at the insertion of medial rectus. And indeed, great Kavita, you could find out the medial rectus because, as ma'am has rightly said, it is one of the muscles which is never found when it is gone behind. So if somebody is pulling the muscle, then the pitting is usually 5 millimeters behind the insertion. Now it is difficult to get the muscle back. So that's usually the thing with the
probably
medial
because of the lipodermoid, the muscle
Yes.
didn't slip back further. It was attached
Yes.
to the conjunctiva there, and it
So
was
I
easier
found
to
some,
find.
yeah.
And also, ma'am, the cut was anterior, just at the insertion of the medial rectus. If it is further
Yes.
behind, then it goes behind and behind and behind, and it's lost.
Yeah.
Yeah, Dr. Kavita, I think that was very nicely done. And
thank you, sir.
that lost or slipped muscle is definitely a nightmare. And
That
few
too, it
years
was a
back,
COVID times.
yeah. So few years back, we were taught that if a muscle is lost, you just need to stretch the tendons. So that will give you the opening from where that muscle has come inside towards the globe. So have you had any chance to do something like that, or what is your take on that?
Did not have the chance that way.
Okay. So
It's
you
very,
don't know
very
whether
rare. Usually people lose medial rectus during pterygium surgeries. So that is the most common during RD surgery. I rarely found anybody losing medial rectus during RD surgery.
Okay. So stretching the tenons capsule to look for the opening, whether that works or we don't know whether that works or not.
So your opinion, Shubhangi madam's opinion for that, or Ankur, any opinion stretching? I have never tried it out.
No, I don't think it works that way, sir. I think, as Arushi rightly said, more the stretching you do, more behind it goes actually. So, in the panic, if you try and search more and more, it goes further back and back. That's the problem.
So the search was completed by the retina surgeon. A lot of search
No,
was.
I
By
mean,
the time I was coming, a lot of search was already taken.
No, your search versus the retina search, we understand the
Yeah,
handling
yeah,
of
yeah.
muscle is different, from
Yes.
different perspectives. So Shubhangi ma'am will also agree, like when you are seeing the sutures being passed under the muscles, it must be aching in your heart.
Yes.
The way the muscles were handled.
Yes.
Yes, Dr. Rahul Tiwari. Dr. Rahul, you want to say something about this retina surgeon case? Any experience as a VR surgeon regarding this? You are
No,
doing
sir,
retinal
it's a
detachment
nightmare
case.
for any retina surgeon to and as everybody says, every cataract surgeon should have a good retina surgeon friend. So every retina surgeon should have a good pediatric or squint surgeon friend.
I just want to pass one comment in that I have mentioned a notion. The saviors also can sometimes get stuck. So retina people are always the saviors for all the cataract people, and it's like this. So anything can happen anytime.
Thankfully, the silicone the encerclage for the retinal detachment is going down now. It's more on vitrectomy and all those things.
Yes.
And it's amazing to see the call to the squint surgeon. Usually we call the retina surgeon from OT most of the time.
Madam, do you have any experience in which case you feel that the muscles may remain a little weaker side?
Pardon? What do you mean by weaker side? Like what?
Yeah, I mean, you have to stretch quite a bit to take a bite in the sclera for fixing the.
Yeah, that the sclera is very thin. Just it is say about bite when you are taking the bite has to be the needle has to be visible and it has to be a swishing movement so that and it comes out.
You know what?
No, sir,
we
you're
have
asking
we
the
have
risk of-
so far 2 cases, and like you, I was also lucky to help my retina person to achieve the medial rectus. But there's a correlation. The patient was diabetic since more than 20 years, number one, and the patient was asthmatic. Could these two things probably cause the muscles to be, weaker side or weak, and then probably detachable or probably breakable?
So per se you cannot say, but definitely anti-cholesterol drugs, they lead to muscle hypertrophy. And diabetics usually are not just diabetic, they are apart from diabetes they have hypertension and they have cholesterol also, hyperlipidemia, and they are on anti-cholesterol drugs for many years, say 10, 20, 30. So it all atrophies their muscles and they become weak. I don't know about ocular muscles, we have not done any study on that, but definitely physically if you see a diabetic male or any patient with anti-cholesterol along with that will have muscle wasting.
So can we take some precautions, like instead of hooking it, after hook, you can take a bite on the muscle and then keep the stitch there.
That is a very good idea. That can be done. But I don't know, retina people, do they ever take bite in the muscle?
We will teach them.
Sir, actually, it can damage the muscle's blood supply if you pass.
Yeah, that's what my point was. That only because they are not. Everybody is aware, but squint people will be more aware of taking the blood vessels and taking into account the blood vessels and the supply for the anterior segment, because they are tackling all the 4 muscles. If all the 4 muscles they are putting a bite and suppose they are tying or just for holding it, it may lead to anterior segment ischemia.
I think it's more in the medial rectus rather than any other recti muscles.
Okay, that is fair enough. That is fair enough. But only thing is vasovagal has to be kept in mind.
Very nice presentation. Thank you so
Very
much.
nicely salvaged case, Dr. Kavita. Congratulations. Now we move on to our next speaker for today, Dr. Rohit Bang. He is from Sambhajinagar and he is a fellow in cornea and refractive surgery from Shankara Nethralaya, Chennai. He He has been associated with Sir JJ Group of Hospitals and Sri Ganpati Netralaya as a cornea consultant. Presently, he is working at his own Sri Krishna Netralaya, Sambhajinagar, and is also visiting surgeon. At biggest government facility at Baghdad, Iraq, as corneal surgeon since 2017. So, any of you having some crisis in petrol and diesel, you can always contact him. He is direct links with the Iraq. Welcome, Dr. Rohit.
Thank you, sir. Thank you.
You can now start.
Yes. It's not coming to my screen. Hello.
Yeah, we are not able to share your screen.
Not really.
Now. Yes.
No. Still not able to. This site will be able to.
Rahul?
Rahul?
Yes, sir. Yes, sir.
Now you can try. Rohit?
Yeah, I'll try. Yeah, 1 minute. No, it is choose what to share with the Zoom app. This site will be able to see the contents. Not really.
रोहित सर तुम्ही स्क्रीन थोडीशी छोटी करा तुमची त्याच्यामध्ये खाली शेअरचं बटन त्याला डायरेक्ट क्लिक करा तुम्ही एरोला क्लिक करताय बाजूच्या
शेअर स्क्रीन
ग्रीन एरो
नाही ना त्यालाच क्लिक करतोय मी जे शेअर स्क्रीन आहे किंवा ते ग्रीन बटन किंवा त्याच्या खाली शेअर स्क्रीन आहे
now you can John is able to share.
ते शेअरच्या वर एक एरो दाखवलाय त्याच्यावर डायरेक्ट क्लिक करा सर
ओके पण
काम कीजिए आई थिंक एक बार लॉग आउट करके वापस लॉग इन कीजिए आप Zoom में आई विल टेक द नेक्स्ट स्पीकर इन द मीनवाइल
ओके
so the next speaker is Dr. Prasanna. Just a second.
Is Dr. Kavita related to Dr. Amit Porwal?
Yes. She's wife of Amit Porwal.
She's the better half. Okay.
Yes.
Very nice.
So our next speaker is Dr. Prasanna Venkatraman. He is Senior Consultant Glaucoma Services, Arvind Eye Hospital, Chennai. He has done his glaucoma fellowship from Arvind Coimbatore. He is a consultant in Arvind Chennai since 2018. He has presented in various national and international conferences and many publications also to his credits. He is well trained in MIGS, tubes, and has keen interest in managing pediatric glaucomas. Welcome, Dr. Prasanna. You can start sharing your screen and start your case.
Good evening, sir. I'll share my screen now.
Yeah. Prasanna, you can also start your video also. We are not able to see you.
Yeah. Can you see now, sir?
Yeah, definitely.
I'll play the video now.
Yes, please.
We will go through an unplanned cut in this video. This is a re-surgery for a complicated cataract surgery done elsewhere. Plan was to suture the leaking SICS tunnel. Since the pupil was irregular, an attempt was made to retract the iris to check for haptic position. Note the dense sommering ring. Iris hooks were used to better visualize the extent of the ring. Bimanual automated vitrectomy was done and then switched to IA cut mode to remove the ring. As expected, it did not budge. spatula was then used to try to free the ring from the equator of the bag. IA cut mode was again used to disengage the ring from the bag, but all attempts were only pulling the weak bag. The fear of dropping the IOL was always there. Finally, a chunk of the sommering ring was expelled out. It was now decided to explant the IOL instead of risking an IOL drop. Back to square one again. With gentle pull, the ring was attempted to tease out of the bag, but all maneuvers were only pulling the bag. How long can this go on? It was decided to sacrifice the bag and remove this ring altogether by visco expression. Leaving so much lens material inside can lead to refractory inflammation and glaucoma. Automated vitrectomy was again repeated and the anterior chamber cleaned up. After securing a relatively round pupil, iris claw IOL was enclaved. The main port was sutured and visco washed from the AC. A surgical PI was done and the case closed finally. Many lessons learned in this case. No surgery is a simple surgery. Always be prepared for surprises.
Stop sharing the screen now.
Excellent video, Dr. Prasanna.
Thank you.
Yeah, do you have some preoperative pictures of this patient?
No, this was actually a resurgery. So this came to us only for tunnel suturing. So that was why we took the patient. So we don't know what the primary diagnosis was. So in the notes, it was just documented as phagolytic glaucoma bar absorbed cataract. So we wanted to suture the tunnel, but had a surprise on table. So that was what we thought. So it could be an absorbed cataract or it could be a sommering ring, but that is what we saw. So this is not a primary surgery.
Yes, Dr. Kashyap sir.
A fantastic thing, and you everything is not in your hand. You were lucky on that day that you saw all these things. Normally, the old surgeries, old operative cases, you get a lot of these kind of rings, and then what I generally do is I push from the equator side towards the center. So some of these rings they tend to come out a little faster. But if they are so adherent as in your case, I think you have done the best.
I personally have a question in this. When you were taking out the ring, you did visco expression rather than why did you could have used vitrectomy in anterior, taking anterior to the iris and vitrectomize the sommering ring and eaten up everything.
I was trying for a very long time. No, I was trying for a very long time with the vitrector in IA cut mode as well as vitrectomy mode. It was not budging. So that's why I had to finally sacrifice the bag and put an iris claw.
No, when you were sacrificing the bag, you did a visco expression. right?
Yes.
So I'm
Yes.
telling, when you are taking out the bag, you could have taken the bag in the anterior chamber, do the vitrectomy, and then you proceed with your iris claw or SF or whatever you want to go ahead. That is my opinion. So I would like others' opinion also in this, by doing a visco expression, because it can.
I think, I think he has done a perfect job, madam.
Yeah.
Because they are so used to the visco expressions for the SICS, they are expert people. And then if it is good in their hand, probably why not? Yeah, good thing.
I was just wondering, what was the cause for taking up the patient into surgery? Like, was it a hypotony?
Yeah, hypotony. It was a temporal tunnel. So it was a leaking temporal tunnel. So we had to, the aim was only to suture the tunnel. Since the pupil was irregular, I noticed all these things.
So you tried to regularize and make it round centric kinds?
No. I was just wondering what was happening, because when I put air bubble in the AC, the pupil was, I could see the IOL optic. I was wondering why there
was the first surgery?
It was 3 days old, sir. There was a PCR that was documented also.
No, this surgery was 3 days old. Like the IOL and everything was put 3 days back.
Yeah, 3 days old, sir. Came to us with hypotony, so we took for temporal tunnel suturing. That was what our aim was.
It's more of an absorbed cortex rather than sommering ring.
Yeah, it's like a partially absorbed. And was the leak checked actually, Dr. Prasanna? Like, did you do a CDLs to check for the tunnel leak and all those things?
Yeah, I did not show that, sir. IOP was 3.
No, but we did have a leak from the tunnel.
The temporal
CDLs, the CDLs and the pressure CDLs both were positive kinds.
The temporal tunnel was leaking. The pressure was
temporal tunnel was leaking.
Yes.
Got it.
AC was also shallow.
And it was
No
CD
I
after
think-
that.
Yeah.
It was
Yes,
perfect,
madam.
no CD. Later on, no CD, nothing. Hypotony was so high. You had a lot of hypotony in the patient. No CD, nothing. Everything was posterior.
Choroidal detachment.
Choroidal detachment.
We're asking about after the resurgery or after the primary surgery, madam?
Primary only, because the hypotony was there. Posterior was fine. Like.
Yeah, posterior segment was okay. It was only 3 days old.
But anyway, it was a nice surgery, Prasanna. Worth appreciating. You did a great job.
Thank you, sir. Thank you.
Yes, Dr. Rahul.
Yeah, sir. What I wonder is if it is a somerous ring, or even if it is a partially absorbed membranous cataract. In either scenario, if the IOL is stable and eye is not inflamed, what is the need to remove that cortex which is way behind the equator, is not disturbing a vision?
Behind the pupil.
Yeah, behind the pupil.
My only concern was so much lens material in the eye, it will cause inflammation and glaucoma. So I didn't want to leave all those. So we have seen many sombering rings causing secondary angle closure and glaucoma. So leaving such a huge amount of sombering ring behind the IOL, I felt that was not a good idea on table. So I thought of removing it.
Dr. Prasanna,
yes.
What I saw the wide structure, either the cortex or somerous rings, I think it is long standing. It could be 3 days or something. I think there is something somewhere, some confusion somewhere. Because and if it is fresh, it cannot be so stuck so hard, and that you cannot remove it. So it has to be very long standing.
If the PC was intact, I would have just left. Since there was a PCR also, I didn't want all those inflammation to just extend to the posterior segment. That was the only reason that I took it for.
Can I ask one more question, Dr. Prasanna?
Yes, madam.
It leads to angle closure glaucoma, you told, right? Secondary angle closure.
We have seen.
Think of cortical matter coming to the angle, it will lead to like open angle with a trabecular meshwork block.
Yeah, that is one mechanism. I'm talking about.
Matter. It wasn't soft anyways, but per se.
Yeah, that can cause open angle. We have seen sombering rings, especially in children, pediatric cataracts. We have seen years later that sombering ring causing secondary angle closure with the iris bombay and all those things.
Pediatric cataract, right?
Yeah,
pediatric
like a secondary cataract.
Secondary angle closure glaucomas.
Yeah.
But I think I would have been very kind of a conservative surgeon. I would have just put an air and sutured the tunnel and left it at what it was.
Yes, yes. Even I also did
That,
this. Would have done
that
this.
was what was unplanned. I did not plan
Yes.
on.
The first surgeon also had some unplanned cuts there,
Yeah,
and you also
yeah.
did some unplanned cuts on top of that. Dr. John, you want to say something about this case? We are not able to. You are mute. You are muted.
John, you are
No,
muted.
Dr.
You'll have
John,
to
you are
unmute
muted.
yourself.
Nothing much, sir. As glaucoma surgeons, we don't like to leave these things behind. So I perfectly understand Dr. Prasanna Venkatraman's point of view.
No, John, but sometimes it's better to sit tight on glaucoma. Not going in is also a part of managing glaucoma in most of the cases. So, I mean, in some tricky situations. So
Right, sir. And of
maybe
course, the visco expression in Arvind, we are very much used to the visco expression. So it's, I mean,
We are
it's
also from
second nature
Arvind,
for
but
us.
for
We don't
sombering
think
rings, I
about.
had a second thought.
My
no, it was
only
not getting cut
objection
with
was
the
to the
yeah.
my only objection was to saying it Sommering's ring, because
Yeah. It's
Those are
very
absorbed
easily told.
membranes.
It's not a Sommering's ring. It's just retained cortex.
I also thought it was absorbed cataract, but it was refusing to come with vitrector also. So
Yeah, it's not
why
getting
it
cut
should
by
be so
vitrector.
dense? That was the
Yeah.
only question.
Right.
So there's no point in trying to cut again and again when it is not getting through with the vitrector.
Yeah.
So it's the expression was okay. I mean, it was a well done thing, well thought of.
Dr. Ashwin, you want to comment something?
Yeah. So, Dr. Prasanna, what I'd like to ask is, when you went inside, was there vitreous in anterior chamber?
Yes, sir.
Okay. So,
So that's why I
I
started
think,
with vitrectomy after putting
right,
it. Yeah.
right. So, I do agree that this entire cortical matter which is there, this is not a sombering. This surgery was done 3 days back. So the entire thing was there. It has to come out. There's no way you can leave this, behind. There's a lot of inflammation it's going to cause. But after you've done vitrectomy, the thing is, this piece actually it's all sitting in the capsular fornices. It doesn't come off easily. It tends to come either as a one bolus if you try to visco express it. So with vitrectomy port or even with bimanual port, which are very small, it usually doesn't, you are not able to catch hold of this. So either you do visco expression, you go at, in the capsular bag fornices and try to put visco there so that, the entire piece tends to come off.
Visco
Or
dissection.
you
Visco
go with,
dissection.
visco expression, that's what. Or you use a Simcoe cannula, which has a bigger port. You may be able to, catch hold of it and then the entire sheet will come off. So I think that's the only way, but it has to come out. There was no way that after seeing this, you leave it. So that was wonderful what you have done, Dr. Prasanna. I agree.
Thank you, sir.
Great surgeon, yeah. So next, Dr. Rohit, you are now ready with your presentation?
I hope I can share the screen.
Please,
I'm ready.
please start sharing.
Yes.
So Dr. Rohit is practicing at Sri Krishna Netralaya, Sambhajinagar. Still not able to share? I think in your settings, Zoom settings, you have not given permission to share.
If not, I am ready with my video.
Yeah. We'll just. Dr. Rahul, Mr. Rahul?
Rohit, you can see the share screen, share icon
I'm clicking
there,
on that. The moment I click, you're able to see this is showing entire screen or something. But it's not. Okay.
No. We are not seeing anything on the screen.
Yeah,
now you can
it's
see.
there. Yes.
Yeah.
Now you're able to see.
Yes,
Okay.
yes.
Okay. So, 1 minute. So this was a case of a. Hello.
Nothing is coming. Nothing is coming. Your PowerPoint is
1
not
minute.
playing.
Now?
Yeah, you can see now.
Now it is coming. Now it is coming.
Now it is coming.
Yeah, it is coming now. Go ahead.
So, yes. So this was a case of a routine phaco, which was being managed by one of our phaco fellows. And as you can see, everything running smooth. Good round circular pupil. And a very good rhexis, a big rhexis. It is almost a nuclear sclerosis grade 3 or something. This is just to highlight what has to be done and how things can go wrong in an unplanned way. So after the rhexis, She's trying to do the trenching part. You can see little bit of her moving the nucleus or some sort of a harsh movements. And with a very superficial trench or one or two trenches trying to crack. Generally, as a fellow or something, we just try to rush things which should be avoided. And once if that is not enough, what is happening here is we are trying to rotate the nucleus and try to trench it from the other side. So after trying enough, as you can see that there is a tendency of that phaco probe also to come out of the section. And by the time that there was a lot of hush and push, we see that there was a zonular dialysis. So this case is now being taken up by the primary consultant instead of a fellow. And the best way to manage, there could be two school of thoughts. Either you just convert it to the SICS or you continue with the phaco. And we thought a very good use of iris hooks to stabilize the bag and then do a phaco emulsification, which was done, I think, very efficiently. And similar thing with the cortex was removed. So after doing all these things, the assessment was taken. What next to be done? Either put a CTR, but we also had a PCR and little bit of a vitreous that was coming out. So we decided to close the case on that day and take up a case on another day and plan a iris claw lens. So as you can see, after doing a vitrectomy, making sure that no vitreous was there in the visual axis or in the antechamber, we go and put up try to put up an iris claw lens. A very good thing would be using a iris claw lens forceps, which gives a very good stability. So when we thought that it is enclaved enough and the job is being done, next day morning, what we see that my iris claw lens is still dangling in the vitreous cavity. Fortunately enough, it was attached or enclaved enough at one side and the other side it was not. So it's a double trouble that the side where it has been enclaved should not be damaged. At the same time, how to go ahead and do the job which is left. So first and foremost is very gently try to bring this iris claw lens onto the pupillary plane, and at the same time at the other side it should not be the iris should not be damaged. So very good use of a viscoelastic material to protect your endothelium, at the same time not damaging the iris. With a dialer and a repositor, I am trying to put it in a position of a convenience or horizontal position. Pilocarpinate the pupil again so that you have a very good understanding where your enclavation should be done. So now I think that this iris claw lens is sitting nicely. Again, go and hold it with the forceps. And with the repositor, just go and do the enclaving part. And as you can see, the dimpling of on the other side or the ovalization of the pupil, now I am very sure that it is enclaved enough on both the sides and the job done. Thank you.
Excellent acrobatics, Dr. Rohit there.
Thank you.
Lot of it unplanned, I think. So, yes. Dr. Rahul Tiwari.
It was like two or three things, superficial trench and trying to crack the nucleus before the trench was adequate enough, and that could lead to unnecessarily stretch on the zonules and zonular dialysis. And at the same time, enclavation has to be properly done and make sure that the iris claw lens is very well enclaved, or it might at times then just hang around or at times drop into the vitreous cavity also.
Yes, Dr. Rahul, you have lots. Yeah, please, sir. Go ahead.
Yeah, the thing is, sir, basically, these iris claw lenses are very difficult to untuck. Once they are tucked to the iris, they are very difficult to untuck. Almost impossible. I couldn't do it. There was a case where similarly one side this iris claw was hanging down, but the hanging down portion had a broken, that tuck portion of the IOL was broken. So I couldn't retuck it. So I had to remove it by doing the iridectomy from the tucked area. This was somebody else anterior segment surgeon's case. So I usually prefer doing a vitrectomy, going from pars plana and putting a gluteal lens in these cases, and they go better in my opinion. But yeah, there are. This is the problem with these iris claw lenses. If they are hanging down, if you have to untuck it, it's very difficult to untuck.
Kashyap, sir?
Sir, this iris claw lens, I don't do it. I don't do it. It doesn't mean I don't want to do it. I cannot do it. It just doesn't happen with me. I don't know how to tuck it, how to, push the spatula, between the claw, how much it has to go, and what should be the people, shape. So it is very, very tough job for me. I don't do it. Thought dar lagta hai size claw se. And glue out is fine. It's so nice with all those modifications.
I think it's relatively easy as compared to your SFIL or even like whatever glue dial or something, and especially I would say that Dr. Rahul would agree, for the anterior segment surgeons it feels to be relatively easy as compared to your SFIL.
I do agree,
if
sir.
you do not have access to the VR, yeah.
Sorry.
Dr. Manish, you want to say something? Manish?
Dr. Rohit.
Yeah. Joshi sir. Yeah.
Manish is there, I think. Manish can comment.
Sir, for anterior segment surgeon like us, I think iris claw is the best way to rescue the time and the situation, because we have already promised a lot of things to the patient relatives while counseling, and at least if there is no lens, there is no payment. So for iris claw, I think in all the situations, it is a rescue for us.
Okay. Yes, Joshi sir.
Dr. Rohit, very well managed case. In fact, dealing with such case which was done by resident having some problem, it's really creditable.
Yes.
But just I want to ask you, was there any capsular bag which was there, and you could have implanted endocapsular ring and saved the day?
Agreed, but with the zonular dialysis of like more than 4 to 5 lakh hours. Hello.
Yes, okay, yes,
hello.
Yes, go ahead.
And a presence of a PCR also. There was also postcapsular rent.
Okay. Yeah.
Double trouble.
Yes. So with the zonular dialysis and PCR, I thought putting in a CTR would also be difficult.
Okay. Yeah. Very well managed.
Thank you, sir.
Great case.
TR. If you put the CTR in the TR, posterior capsular TR, it will increase the TR also. It may fall down sometimes.
Just having a zonular dialysis and putting a CTR would be a good option, but with the presence of already a zonular dialysis and
if TR is, if posterior capsular TR is there, you must not put CTR, because it may increase the TR also, no? Because of the pulling action or not.
Yes.
PCR is a rather contraindication with CTR.
Yeah, rather very nice, Dr. Kashyap.
I would like to add a comment.
Yeah.
Yeah, very nice surgery, doctor. I would definitely say, but just because we were talking about iris claw versus SFI, as a VR surgeon, because I have initially done iris claw lens also, and we all know many VR surgeons who are also doing iris claw lens. But for anterior segment surgeons, I believe that iris claw lens, if there is a lot of vitreous loss, then it should not be, because we are not able to maintain the vitreous cavity. So in that case, most of these cases land up with VR complications later on. So if there is excessive vitreous loss, in that case, I think iris claw lens should be avoided by anterior segment surgeon if a lot of vitrectomy has been done and liquefied vitreous was there. Thank you.
Why? I could not get it. Like if vitrectomy is done, you want to put SFIL rather than iris claw lens? You mean to say that?
No. Actually, Dr. Kavita, what I was... Yeah, please brief it, sir.
Yeah.
If huge amount of vitreous loss is there, you should not put iris claw because it may have some posterior segment complication. That is what he wants
Okay,
to.
for
explain.
future,
Yeah,
future
you have
treatment.
to have complete
That's
vitrectomy, then you can.
Yeah.
Yes.
Because anterior segment surgeon in that case, ma'am, cannot maintain the vitreous cavity, just
Yeah.
viscoelastic or keeping anterior segment infusion. Yeah.
Yeah. But most of the anterior segment surgeons are comfortable with iris claw rather than
Iris
SFIL.
Yeah. But ma'am, because we also come
Hmm.
across complications of iris claw length, so I thought
You're
that just a
correct, you're
small
correct.
point,
Yeah.
point I would like to put.
Yeah, that was a good point actually.
But iris claw only once we try to attempt, on the next day we don't see the iris claw is there. I think we always call our VR friends there.
Yeah, thanks.
But
That is very honest, sir.
Yeah, what I feel is
Excellently.
important is the thorough anterior vitrectomy is prerequisite. Either you go for a glue dial or you go for iris claw. A thorough anterior vitrectomy is important. And if there is hypotony or if you have put a posterior infusion cannula, then a complete vitrectomy is a good idea.
Excellent case, nicely managed, Dr. Rahul. Dr. Rohit, as usual. So our next presentation is by Dr. John Davis Akara. You can see my screen. So Dr. John Davis is a glaucoma, cataract and refractive surgeon in West End Eye Hospital in Chaitanya Institute, Kochi, Kerala. Was formerly a glaucoma and cataract surgeon at Little Flower Eye Hospital, Angamali. And he's done his MBBS and MS from JIPMER with fellowship from Arvinda Hospital and Ratan Tata Advanced Cataract Fellowship from SL. He has presented numerous papers in various national and various international conferences. He's a very innovative mind and techno-savvy. He has got innovated many foldable fundoscope and virtual reality perimetry and all that. And he is also very gadget and technology savvy. He's especially in 3D printing and website designing and all that. He also holds a patent for foldable fundoscope and is also won a startup challenge for and incubation. Welcome, Dr. John. Dr. John, you can start sharing your screen. Yeah.
Thank you, sir. I will go ahead to the video itself.
Yeah.
Navigating the glaucoma gate, blood barrier and pupil problem. This 74-year-old lady presented with advanced glaucoma, status post, strab in both eyes, and immature cataract left more than right. Note the awkward position of the right hand side port at 10 o'clock position because the bleb extends from 10 o'clock to 2 o'clock. The left hand side port is at 5 o'clock position and is used to inject trypan blue dye. Look carefully at 11 o'clock position. See how the trypan blue dye enters into the bleb and stains it. That shows a functioning filtering trabeculectomy bleb. Avoiding damage to the conjunctiva, a temporal clear corneal incision is made. Because of the small pupil, a BHEX 2.0 ring is used. The ring is inserted into the anterior chamber using the BHEX forceps. Then the alternate flanges are tucked under the iris, and this allows the pupil to dilate to 7 millimeters. The third and last flange is often the most difficult one to engage. You might have to use a Sensky hook to hold it and use a BHEX forceps to bend it and place it under the iris. Then you can continue with capsulorhexis. Here the capsulorhexis is initiated with the right hand, and then halfway through it is found to be difficult to continue using the awkwardly placed 11 o'clock side port. So I switch hands and continue the remaining part of the capsulorhexis using my left hand. Beam ambidextrous is a very useful skill for an ophthalmologist. Hydrocannula is used to wash out the capsular remnant and some viscoelastic. Then hydrodissection is done. The dialer is used to dial the nucleus to make sure that the nucleus is freely rotating. Phacoemulsification is done by stop and chalk technique, where first a trench is made and the nucleus is divided into two halves, then rotated, and then the halves are chopped into quadrants. The quadrants are also further sub-chopped into smaller pieces. Care is taken to do the phaco under low parameters to avoid damage to the bleb. Viscoelastic is replenished as necessary, and care is taken to avoid damage to the endothelium as well as the capsular bag. After the nuclear management, cortex is removed by using bimanual irrigation aspiration. First, the aspiration is in the right hand and irrigation in the left hand. And once half of the cortex is removed, the hands are switched and the irrigation is in the right hand and the aspiration in the left hand. The cortex is completely removed and then the anterior chamber is filled with viscoelastic. A foldable single-piece monofocal intraocular lens is implanted into the bag and then dialed into position using the dialer. After the anterior chamber is replenished with viscoelastic, the BHEX pupil expander is disengaged by holding the center of a flange and pulling it into the anterior chamber. After it is disengaged, it is removed by pulling it out with a corner. Viscoelastic is washed out by using bimanual irrigation aspiration. The incisions are hydrated and the pressure is titrated. The preoperative visual acuity was 3/60. Post-operative improved to 618 on post-op day 1, 69 on post-op day 7, and 66 parts on post-op 1 month. Thank
We have glaucoma consultants, the discussants, Dr. Anindya Anuradha from Jharkhand and Dr. Ankur Sinha from Rajasthan.
Dr. Chan, it is very nicely done. Am I audible?
Yes, ma'am. Thank you, ma'am.
Yeah, I really feel like using BHEX really helps in glaucoma cases than using this iris hooks. It really compromises the anterior chamber. So I'll say it's very well managed with this BHEX.
Thank you, ma'am. I once I got BHEX, I keep using BHEX for all the small pupils. I never use iris hooks unless it is a compromised bag or something and you want to hold the.
But in this case, iris hook cannot be used. It's always BHEX ring.
Yeah.
Absolutely.
Yes.
John,
excuse me, madam. Why do you say so? Why do you say so?
Because
too many holes.
Yes,
it doesn't matter. What I feel that the pupil dilator should be used when you cannot dilate the pupil beyond 2 to 3 millimeters. If you can do the surgery in 5.5 to 6 millimeter surgery, all these pupil expanders, they dilate the pupil by 6.5 or something. There are other tricks to do the cataract surgery in small people.
Yes, sir. This makes it easier. It's like if you could do it in a smaller pupil, or you could do it a little more safer. So this gives an extra protection when you have that. And we couldn't put extra side ports because a bleb is there. You had no place to put extra side ports for all the iris hooks you would want to put.
No, my statement was not for your case. In general, I was talking.
Yes,
my
sir.
question to you is, I want to learn something from you. To avoid the blockage of this so-called patent trap channel, I mean the patent bleb, what all do you do to take precaution that is not blocked, it doesn't get blocked?
We just have to be careful with the iris and anything which goes into that area. So just have to be careful to keep the iris away from the ostium. Make sure that there is no damage to that. Don't have too much inflammation happening. All those things.
Yeah, it's the inflammation which is the cause of failure in these patients rather than the physical blocking by the iris normally. John, I wanted to have a few questions. It's actually a very good surgery, nice surgery, and a very great result, I want to say. Was it a weeping bleb or a very hypotenuse eye? Because the amount of trypan blue went into the bleb was actually huge, humongous.
Yes, sir. Actually, it was not hypotenuse. So I was surprised that such a huge amount of trypan blue went in there. I was not expecting that.
Because normally we do have a little bit of leakage of trypan blue. So just word of caution, in very thin blebs and large blebs, then even while applying the speculum, you have to be very, very careful, because that's where you can damage the bleb. So what I suggest is, put it temporarily and then gradually shift nasally with the flanges going beyond the bleb and then moving it.
Speculum. Oh, yes, sir.
Yeah. So
Okay.
the speculum
Okay.
application, speculum removal is one part which is very important in these cases. And I think you have done it well. Maybe you have to cover it with a little more of steroids to prevent inflammation, which can, as Kashyap sir was kind of fearing failure of the bleb post cataract
Yes, sir.
surgery, which is actually very, very high.
Yeah,
And,
what precaution I take is that I do not inject a lot of viscoelastic, because they are the agents which can block your bleb. So you have to be very, very careful.
Viscoelastics are also known to add up to inflammation and then add up to kind of further failure of the bleb. If it's HPMC, if it's sodium hyaluronate, maybe it will not add up to inflammation. It will come out as a bolus. So that's what I think. Well done, John. Great
Just
job.
one question,
Sir,
John.
Yeah.
May I speak?
Yes,
Yeah,
please go
please
ahead.
go
ma'am.
ahead.
Yeah, just one question. Have you ever encountered any problem with BHEX, the loop getting stuck or pulling the iris or entanglement of iris and leading to iridodialysis? Anything
Very
such?
interestingly, yes. So I usually have PIs temporarily, and because I had a BHEX get entangled into the PI, which was temporal, now I make sure that all my PIs are nasal. So I had that. I had a BHEX get entangled into a PI.
The good part of BX is when you are doing these cataracts, which are post trabs and all, sometimes they are very shallow AC. So it just places go there and keeps the iris posteriorly. It doesn't come out into the incisions
Compared
and
to the iris hooks.
yeah, because iris hooks tend to pull it
They pull it
anteriorly.
anteriorly.
Yeah, BHEX keeps it down into the pupillary plane, so it works well, especially with the operated trabs and shallow ACs, which we actually are little encountering it.
Sir, I will like to add one thing. The washing the visco in the bleb area, actually in the subconjunctival surface, is very much important, because this visco induces more inflammation and bleb failure. But this is very tricky, because many of the times when we try to move our irrigation cannula more to the bleb area, the bleb actually start more blushing, and this can induce the future bleb failure. So we can inject the 5-fluorouracil injection at the end of the surgery near the bleb areas. In the cases where we are fearing that visco is left behind or more complicated course has been done during the cataract surgery. So any opinion of the house?
So if you're then that way, you can plan to put one bolus of chondroitin sulfate and sodium hyaluronate at the bleb area and then proceed with your surgery, because it stays there if it can. But yes, trying to put more infusion towards the bleb area is going to inflate it more, and thin blebs can sometimes actually rupture. Like we do get sometimes a call, Ankur, you have done a great surgery. Now I was doing a cataract surgery, the bleb is gone. So I said, okay, fine, send it back to me. Now close it and send it back to me. So we kind of take out conjunctiva from somewhere else and paste it there and try to salvage the globe somehow. So it's always better to be, again, a conservative thing for the bleb, that, do a minimum intervention, minimum injection of many things and do a surgery.
Okay.
Excellent case that Dr. John. Our last speaker for today is Dr. Avilasha. Dr. Avilasha Mohapatra she has done her MBBS and from Jipmer Pondicherry and MD Ophthalmology from RP Center AIMS, New Delhi. She has also done her DNB Ophthalmology and fellowship in glaucoma from PGI Chandigarh. She is a past senior resident of JNEs in New Delhi, and now she is working as phaco and glaucoma consultant at ASG Mumbai. Welcome, Dr. Avilasha. You can now start sharing your screen.
Good evening, everyone. Yeah, sure. Thank you. I want to thank Jharkhand Ophthalmological Society for this opportunity. And I'll be sharing one of the cases which I had done in my fellowship. So just a second. So is my screen visible?
Yes, Dr.
Yeah.
So we have a 8-year-old girl with both eye PCG with operated goniotomy. Her best corrected visual acuity was 6/36 in the right eye with uncontrolled pressures on Dimox and 4 AGMs. So we had planned for right eye combined trabeculectomy plus trabeculotomy. So after putting a corneal traction suture, a limbal-based conjunctival flap was made. The conjunctival dissection was done, and so tenons were separated from the sclera. After which gentle cautery was done, and a scleral flap was triangular scleral flap was made. Cruciate incision was made to localize the Schenck's canal for trabeculotomy. That's when we started noticing a blackish discoloration just behind the scleral flap, even before any full thickness entry was made into the eye. So we suspected a suprachoroidal. We started IV mannitol, and after retina consult, we actually planned to abandon trabeculectomy and go ahead with trabeculotomy alone, as this was previously done goniotomy. So the nasal side was already sclerosed. We went ahead with only temporal goniotomy, and the scleral flap was promptly sutured. So as we can see in the after the IV mannitol, the scleral discoloration has started to resolve and almost had disappeared at the end of the scleral flap suturing. The sutures were buried and the case was closed as usual. Subconjunctival dexamethasone and antibiotic was given. This was the post-op day 1 picture of the right eye with IOP of 6 off AGMs. The best corrected visual acuity was 6/60, and this was the fundus picture on day 1. And after topical steroid course on day post-op day 11, the IOP was 16 and best corrected visual acuity of 6/24.
So nicely managed that case in the end. Yes. I think Dr. Ankur sir.
Yes, Dr. Viral. I think it was a touch and go kind of a situation. You just,
All right.
it's like the
Black
Trump having the
correct,
bullet passing through his ear. So the high IOP, the large globes of the, primary congenital glaucomas and the anatomical distortions you have when you are trying to do a trabeculotomy in these patients can sometimes create all these issues. Sometimes the ciliary body is anterior, sometimes it is posterior. So you can actually induce a suprachoroidal yourself when you are trying to do a kind of trabeculotomy in these cases. So I think overall it's a well-managed case on the table, and it was an early pickup. I mean, it's really great to see that choroidal venting going off in the early period. But yes, you have to be wary of these situations when you are doing, especially the kiddos and the large eyes, especially primary congenital glaucoma. So I think it's well-managed case.
Abhilasha ma'am, may I ask you a question?
Go ahead, sir. Go ahead, please.
Yeah. My question is, how much time do you wait for the intraocular pressures to go down after mannitol injection?
So in this case, the IOP was not high. So this was like a misnomer. So first, because there was a blackish discoloration of sclera, first of all, we had to rule out certain things in our mind that some papers also report that there is a blackish discoloration of sclera when there is excessive dehydration of sclera. So because of general anesthesia and the air conditioning in the room, we made it ambient for the patient. Then we tried to hydrate that area, and as well at the same time we also called a retina colleague. So when they had a look at the fundus, they told there is no suprachoroidal as such, but the choroid appears congested. So you might as well treat it as suprachoroidal. So we started IV mannitol. We asked the anesthetist to manage the BP, and the heart rate were also fluctuating that time. So anesthetist also managed that. So there were multiple things going on at the same time, but the IOP was never high. So we didn't know whether it was suprachoroidal, but it did resolve, and there was a choroidal congestion post-op as well, as we had seen in the fundus photo.
Okay.
So we
Dr.
better
Avilash,
err on the
yeah.
side of
Yeah,
we
Dr.
err on
Avilash,
the side of suspecting suprachoroidal. Yeah.
Dr. Avilash, was it not a better idea to first close the incision and you can have done it at a later stage?
Yes, actually, this was one of the thoughts which I had put across to my consultant. Let's stop the surgery. But as the retina consultant was sure that it is not suprachoroidal, and our glaucoma consultant was also in plan with that, so she asked me to continue trabeculotomy and then close the wound as soon as possible. And luckily, we were lucky actually with this case, I would say.
Actually, the things were looking pretty
It
well in
would be a
control.
better idea to close.
Yeah,
Yes.
the things were looking pretty well under control. Also, if you close one port for a child right now, then this site is lost forever, kinds. It's difficult to again
Yes,
go
that's
back in
true.
and do a surgery here. So, and such children usually require, multiple surgeries throughout their life. So, as a glaucoma surgeon, we would not like to leave that space which is, destined or could have been used judiciously in this patient. So as she mentioned, the pressure was not high and it was reducing, like it just came and was going away as the surgery was progressing. So I think it was kind of maybe the correct choice of thought at that point in time.
How can just
Yeah,
how can we
go ahead.
explain the pressure drop with just doing trabeculotomy on half the side? Post-operatively, the pressure remain normal without anti-glaucoma medication.
PCG, the pathological process in PCG is mostly in the trabecular meshwork, and trabeculotomy is the mainstay of the treatment. Actually, the trabeculotomy is the main factor which controls the IOP in a PCGI. Vis-a-vis adult glaucoma, in which trabeculectomy is more important. In a case of PCG, trabeculectomy actually helps in controlling any kind of corneal edema which is present. So it helps in very fast clearing of the corneal edema, but the main IOP control is because of trabeculotomy.
Actually, to be very frank, what works in which glaucoma patient we actually don't know. Sometimes you have children who have very flat plebs, still they are having good control because of the trabeculotomy. And sometimes you have very good filtering blebs, like John showed us just, in the last surgery. And I was expecting this to be a weeping bleb with a hypotenuse kind of a bleb. But it turned out to have no hypotony, as he mentioned. So I think we all operate, we all do, but in which patient, which part of which surgery is working, I think it's not very easy to kind of say. But yes, scarred trabecular meshwork is that's why you could not do a trabeculotomy in the other side, as you mentioned, because of the goniotomy.
Dr. Abhilash, it was a wonderful surgery, and especially, your quick appreciation of this thing and how quickly you can manage and decide the things. It really matters a lot, and you did it really wonderful.
Nicely done. One of the perks in doing surgeries in such big institutes, you have got retina consultants, senior glaucomas, all in the available in the OT. So, but nicely managed in the end. So with this, we come to the end of this webinar. All the presentations are over. And thank you so much, Jharkhand Ophthalmological Society, for giving us this opportunity to conduct Unplanned Cut. Myself, Dr. Rahul Tiwari, Dr. Rajesh Joshi, Dr. Manoj Khatri, along with Dr. Kashyap Madam. We are thankful to the Jharkhand Ophthalmological Society. Dr. Manoj
Thank you
Khatri
so
is
much,
not
madam.
keeping well. He is down with fever, but he joined it for some time us. And now it's over to Dr. Bharti Kashyap, madam.
No, उसके पहले. You know, the midterm AIOS is going to be in Ranchi. It has been decided from 25th, 26th, and 27th of September 2026. Everybody has to come. I'll take a special care for you people. और भी बहुत कुछ करेंगे. Come over, enjoy Ranchi, and it'll be fun.
He is the organizing chairman, and he has to give vote of thanks. We are really thankful to all of you. So please give vote of thanks the organizing chairman of the forthcoming midterm AIOS, Dr. VP Kashyap.
Oh, I have to do the okay. I must thank you, Dr. Bharti, to give me this opportunity to thank everybody. I thank everybody, all the speakers, all the discussants, all the chairpersons to have spent time on Navami.
Viral Shah especially.
Niral Shah and Dr. Prasanna, Dr. Rahul, Dr. Navneet, Dr. Arushi, Dr. Manish, Dr. Shubhangi, Dr. Rahul, Dr. Kavita, Dr. Bharti, Dr. Rahul Prasad from Jharkhand. So many people. You made this webinar tremendous, successful, and breathtaking. It was fantastic. We never had this kind of a interactive webinar. I really appreciate because in this webinar people gave the lecture of 3 to 4 minutes, and the discussion was tremendous, and everybody had to they put their point forward, and it was fantastic. So I thank you everybody from the core of my heart, and endured people who could help us out to reach to everybody. And in the last, I request again everybody to come to Ranchi. It's a very good place. Weather is fantastic.
State of falls. Ranchi is a place of falls.
Yeah. Brochure will go. But then everybody, all of you must attend the midterm conference. I want to make it exemplary because I'm going to oppose midterm conference later on because it has other problems also. So इस बार तो कम से कम I want everybody's attendance, and let's do it because Ranchi में अगर अभी नहीं हुआ तो अगर अच्छा से नहीं हुआ तो another 10-15 years we are not going to have it, and we have got potential to do it, and we'll show it to everybody, and we'll show that how nice it can be done. So I invite everybody, please come.
Definitely. We are sure, sir, you will do a great job. Jharkhand Ophthalmological Society under your leadership. Bharti madam, everybody, thank you so much for the opportunity. And Dr. Namrata Sharma has already promised that in the midterm, this unplanned cut session will be there. And we will take it in
Jharkhand Ophthalmological Society.
Yeah, definitely.
Spoken to her. She said you can do it.
Yeah.
And they will give certificate of midterm. In that,
of course. Yeah, anything happens in midterm will be given a certificate
of midterm.
Even if you play around, you'll be given a certificate that you played around. No problem. Yeah.
Thank you so much. Thank you. Thank you, sir. Thank you.
Thank you very much.
Thank you, Bharti madam.
Great job, Dr. Bharti. Great job, everybody. Rahul, Dr. Rahul, good.
Thank you, sir.
Dr. Nagenda, fantastic.
Thank you so much.
Thank you.
Thank you all the great surgeons across the country. Thank you, everyone.
And please vote for this
Ankur, yes, we are with you with two hands. Yes.
All the best, Ankur sir. All the best.
All the best, sir.
Thanks, everybody. Thanks, everybody. Thanks.
Thank you, Nagendra sir.
इधर 5 मिनट अच्छा चला जाता है
ठीक है, okay, bye.